Assalamualaikum everyone. Welcome to the Zoom meeting. And today we're going to discuss different topics. Hopefully the team will be ready in a couple of minutes. But I'd like to thank you all for attending the meeting and welcome to the new hours. So please interrupt me when you have questions or any suggestion comments. So today we're supposed to talk about So the agenda is supposed to have transition of care. We'll let the dental group talk if they are here, and then we will talk about mammography and so on, and the EMR. Transition of care here in the US it's different than other places. So most of the time the care starts like the patient comes from home to your clinic, either as a new patient or as a follow-up visit, sometimes acute visits. So you just see the patient, examine them, and then put the assessment plan like anywhere else. So patient comes with UTI symptoms, you investigate, and then you can put them on analytics. And the idea is to get the patient going home and stay at home. In geriatrics, however, sometimes things might not go the same way. For example, patient may have a situation where they need urgent care or emergency. So if they have a fall, for example, ended up with pain in the lower extremity, they go to the hospital, they get the X-ray, and if it shows, for example, it's a fracture, then they will go for surgery. And sometimes it depends on their support system, their home. They can go be discharged from hospital to home, but sometimes this will not occur. So what they do is they send them to subacute rehab. I'm gonna just start sharing the slide. Supposed to be from slide share. So basically, we're talking about the movement of patients from one healthcare to another. Basically, when we talk about transition of care, as I said, you can see them at the hospital. They can come to you in the clinic, the specialist clinic, and sometimes we talk also about within the hospital care system, like they can move from the ICU to the ward. What I want you to understand is that in older patients, sometimes they move from one setting to another. So they need some help or they need some support. So if this support is available, then the transfer can be easily and well organized or well coordinated. Sometimes this will not be as easy. So let's say our patient had a fracture of the leg and they have surgery. They cannot go home because they don't have someone at home they can help them. So what they do, they send them to subacute rehab. There, they will have some staff members who can help them get out of bed, go to the gym, do some exercise, and rest and so forth. As they get their strength back, then they can be able to do their activity of their living, and then they can go home. So we'll touch base on that. So basically, transitional care is a set of actions designed to ensure the coordination and continuity of care across different levels or different settings of health care. So this might include logistical arrangement, education of the patient and family, and coordination among the health professionals. So any questions so far? No questions. Okay, I'm going to just continue. So what we talk about ineffective transfer or transition of care can lead to some poor outcomes, and some studies were done to illustrate that. So it can end up with wrong treatment and delay of diagnosis or management and severe adverse events. So sometimes we talk about patient satisfaction. So or patient complaints might be higher when we don't have good coordination care in the transitional care. And the cost might be higher and increased length of stay if there is no coordinated care. So what the hospitals nowadays do, they have case managers. So they, as soon as we admit a patient to the hospital, the case manager will look at what's the plan after discharge. So let's say the patient who had a fall fracture, they go for surgery. So the case manager will look at if the patient will be able to discharge home, then they will contact the family and make sure everything is set up regarding if they need a wheelchair or walker or some other assistive devices. If the patient is expected to go to a subacute rehab, then they will try to contact the rehab centers around the city and see which one are available, which one is close to the family, so that when the patient goes to the subacute rehab, at least they have the family members visit them there. And the same happens when we admit patients to nursing homes. So as soon as they are admitted to the subacute rehab or the skilled nursing facility, they have their social worker who will be also putting a plan as far as the discharge planning. What is the goal of that patient? If they are going to go home, if they need some assistive devices, wheelchair or cane or walker or hospital bed, something that can be arranged earlier. So this is can be arranged and coordinated as soon as the patient arrives to the facility. During the transition, some problems may encounter or may be happening. The biggest one is the medication error. So we ask that the residents, when they see the patients at the hospital, they make sure they have the medication reconciled correctly. So when they transfer the patient to the other facility, they have their own list of medication in the right order or correctly. Otherwise, sometimes duplication may happen, and I have seen patients who come to the subacute rehab with some medications that they were taking on a previous hospitalization or in the past. So the medication reconciliation is supposed to take place before we transfer the patient from one setting to another. Any questions? Let me ask you, anyone wants to contribute as far as their experience in your training or in practice? You know, some of you are practicing somewhere outside the US.
Hello, Dr. Nader. So I did not practice for so much outside of the US, but right now I work as a clinical documentation specialist in the hospital, and I attend the length of stay meeting. And from that, I know like there are always like trouble of like, you know, the placement or the disposition of especially geriatric patients because of sometimes their non-compliance, their behavior. So it's always an issue placing them, like the nursing home, they refusing to accept these patients who have like trouble with the insurance, or for example, like non-compliance or aggressive behavior towards staff and stuff like that. So I feel like it's an issue, like placing either for like short-term rehab or long-term rehab. So this is what I understood, like from, you know, the case managers every day discussing these kind of things. So it's like a true issue, the disposition.
Thanks for sharing. Yeah, this is an important aspect. So as you mentioned clearly, the case managers, they are struggling on a daily basis to ensure that the patients are transferred or transitioned to the other setting. And sometimes, let's say, rehab centers might not accept the patient because of normal behavior. So there are some regulation as far as that. For example, the nursing homes that I work with, they want 24-hour period when the patient is not one-to-one sitter, because these patients at the hospital, sometimes they need some either medication to calm them down, or if they have behavior, they want someone to sit down beside them to reorient them, and this is supposed to be a free period before they come to the nursing home, because the nursing home, they don't have staff with one-to-one setting, for example. The other point is when we accept the patient to the subacute rehab, if they have behaviors, if they are aggressive, the reflex is to send them back to the hospital. So, and the hospital will get penalized for readmission. So if they send the patient too early to the nursing home and we send them back to the hospital will be penalized for readmission. So this is kind of yeah, problem for the hospital as well. And here, go ahead. Thanks.
Hello, Dr. Nadir. Hello, everyone. Yes. I want to say a couple of things about transition care. Many times there is a barrier in the transition of care. I know you're going to address that in a minute. So one of the biggest thing is insurance. Many times lack of having primary or secondary insurance. Many times there is a difficulty in transitioning from one setting to another, and many times insurance itself, they limits the transition. For example, if there is a need for patient, due to the complexity of their situation, to transition from hospital to LTAC or long-term rehab, uh, because long-term rehab and most of the insurance ask for patients to be able to do rehab for at least 3 hours of day. Many times it is too much for the patients to handle. So that is a difficulty and a barrier to transition safely in order to maximize the quality of care. So, and eventually that patient sometimes end up into the subacute where they need more care, both long-term care, long-term rehab and subacute, they both have their own benefits. Many subacute or skilled nursing facility don't accept patients with only Medicaid uh, because of the low turnout or lower number of the reimbursement also. Many times there is a difficulty, or many times because of insurance, people have to transition early from the skilled nursing facility to either home or going back to the hospital. So, and that increase the risk of re-hospitalization as well. So there are barriers. At the same time, if we talk about the transitional care, that allows um, to improve the cost benefit, also cost effectiveness also, and it also improves the proper utilization and prevent the overutilization of care. So
Excellent. Thank you so much for sharing all these great points. So,
thank you.
yeah, as here mentioned that the insurance plays a big role as far as paying for patients, and the patient condition or the ability to participate in therapy also plays a greater role of where they will end up. For example, if the patient at the hospital and they're able to participate in therapy, as mentioned, they will need rehab, for example, physical rehab or physical therapy and occupational therapy. The inpatient rehab, they will offer about 6 minutes or 90 minutes. Depends on how busy. So they need at least some time to spend time, maybe mentioned 3 hours. It's 5 times a week at the hospital. So if the patient is able to participate, they can get the benefit, and they can get their strength back, and they can get out of the hospital. If they cannot tolerate this long period, then they will end up with a subacute rehab, where they will end up with shorter period and maybe 10 days or maybe. So there are different players as far as deciding where the patient will end up after hospitalization. And go ahead, please. Thank you.
So there's another issue that's facing the transition, also like the guardianship, because most of like the geriatric patients, they're like demented or they lack capacity to make decisions. So that end up like increasing the length of stay trying to find the next of kin or like someone who has like the power of attorney to like, take decisions on behalf of the patient. So I know a patient who stayed in the hospital for like 180 something days that there is no one to like take decision for the patient, and the patient lack capacity. So they has to go through like court to get an like an order so that they can place or transition the patient to like a rehab facility. So that's another problem that's facing like the transition of care to like the guardianship.
So thanks for sharing. Yeah, this is also a very great point. So the capacity or the ability to make decisions. So it's either when the patient has the capacity or able to make decisions as far as where they will go next and education, of the patient and the family is important, and this will help them decide, as you mentioned, where to go if they want to go to a rehab center. It's preferred for them to be near their family or where they live, rather than being transferred to a facility far away. But if they don't have the ability to make the decisions because of dementia or delirium or something, then the hospital will be in trouble, because they need to find someone to decide for them. And sometimes we end up going to the court. Thanks for sharing this important aspect.
Yes, of course.
So let's go back to the slide. So there are some barriers. So we can divide them into 16 level barriers or practitioner level or patient care, patient level barriers. So 16. So usually it's easier to transition when you have a 16 in place. The communication between physicians or practitioners is important. Let's say you are in the ICU, you want to transfer your patient to the floor. So you need to identify which team on the floor you want to transfer the patient to, so that they expect the patient and they can look at their information, or at least their their chart and indication and so forth. So by the time they are transferred, the other team will be ready. The practitioner may not know the patient well, so if you give them the information in advance, this will result in a smooth transition. Next, we talk about the patient level barrier. So assume the patient in chart, they can help, as we mentioned, in identifying our next step. If they have someone to help them, we can ask them to move between together, for example, family member and so forth. So the involvement of the patient in decision making is important. And like I mentioned, if the patient has dementia or they have cognitive problems or delirium, that might impair the process. So we mentioned the levels, and we mentioned the patient level as well. The American Pediatric Society is working to improve the transition of care. So they want us to work on the transition care plan, as we mentioned, if the hospital or the setting or the rehab center setting, they want to have the case manager involved and actively planning as soon as we have the patient. They want the communication to be in care between professionals and develop the policies promoted by public transfer of care. So these are the statements from the AGS. Education is an important part, and we need to do some research in this area. And the goal is to maintain high quality when we transition patients from one setting to another, and minimize the barriers or the problems comes with it. So communication between physicians or practitioners is important. And if anyone wants to share, please go ahead. Your experience. Anyone with any comments or your experience as far as transition of care between patients in the hospital or discharging patients from the hospital? If no questions, we'll go to the next part. So when receiving the patient, let's say in a nursing home, what we do, physician, we will do the same HMP, different people as a new patient. So before the patient arrives, most of the time we'll have the discharge summary from the hospital. So the physician at the hospital needs to finish their discharge summary, what happened at the hospital. So for us to understand what the plan after the patient spends some time at the hospital. So the clear the plan from the hospital, the easier for us to take care of the patient. Again, we need to look at the medication reconciliation. We need to look at what long-term plan, so the patient will need to go, let's say, to home. So we need to assess, and the case manager or the social worker will review the need for other so we need to plan as soon as we get the patient, as far as the job from planning from the nursing home or the substitute rehab. So Dr. Artist Batikar. Hello. So basically, we do history and physical as soon as we get the patient to the center. Then we will get the plan as far as start from the center. Sometimes we are successful in taking care. Times we need to move back, so and back on incidents of other follow. They have stay or national stay. And the goal again to get them home safely, and if they can get their strength back. Sorry about the disconnection. So let's go back. Right. So there are some groups that to improve this process. So the National Council of Care Coalition, for example, are working to improve this process as well. Our goal or their goal is to identify issues and barriers and to improve and fix all these problems or barriers. Evaluate the appropriate referral criteria or the communication between these two settings, for example. The access available technology make it easier for medication reconciliation, for example, for physicians. EMR is a big tool that we need to use carefully because sometimes it may cause problems. They can be used, for example, guidelines or barriers and so forth. So there are some advisory task force out there. So as we mentioned, there are many things that we can do. Our part is education. So for you, when you start your residency, for example, you need to understand that you educate your patients, their families, as far as what the next step is. The goal is to get them home right away, and then the case manager will work with you. And if they want to go to a rehab and then home, then also that might be well organized or coordinated by the case manager. Just you need to understand there are different aspects. It's not your own job to do all that, but in a team work, you can work together to achieve that. You don't have to worry about the rest. I think that's can be discussed later. But my idea of you trying to understand the concept is easier. Your job is to take care of the patient and involve in setting the next step as far as planning to transfer the foundation care to another care giver or care provider. So you need to, sometimes they call it subsequent transfer. So you want to talk to the physician, let's say you are in ICU and they are on the floor, get them heads up, give them some summary of what happened and what's expected. So when the patient transfers to the floor, the other people take care and they start from what you finished, what you can do. So any comments, any suggestions, or any experience from you guys? Go ahead. Thank you. Anyone with any comments?
Yeah, hi, Dr. Nada. Sorry, maybe you will hear background of my daughter crying. She's not like, she's refused to sleep actually. Yeah, I'm basically resident in emergency department here in Qatar, and I just want to add that dealing with geriatric patients, especially when they send them from nursery rooms, it's really difficult. Like we've been in a situation when they bring them to us without like a clear history and like chest pain or whatever, and when we decide that he's not for admission and there is no further plan, the same place where the patient was admitted, they will refuse to take the patient back, and the patient will be stuck for hours. After like as an ED also resident, always we had issue like dealing with them, like there's a lot of medication going on, a lot of issues when you like clear that this patient here, we need DNR when you don't need it. I believe like this so yeah, it's really hard to deal with this patient.
Thank you for sharing. This is also important point. Thanks for sharing. So we can move to the next topic. Any other question? If there is not, we can. So anyone from the dental group or the team? Not, I can take you through the EMR. So we have different EMRs, electronic medical records, that are used in the hospital in different places. There are big ones, and I try to collect some of the common ones. So I'm going to share with you some of the basic tools. So if you go to this website, we collected some. So some of them, they have some videos of what the features. These are short videos. So we can browse them by EMR and by clinic, so or clinical tips. So the big ones, Epic, for example, is a big company. Athena is one, another one. Cerna is another one. And the nursing homes that I go to, they have point click and care. So there are many EMR or electronic medical records, or sometimes they call them electronic health record, EHR. So we will just touch base on some of the basics for this EMR. So this has some training for Athena, like about 15-20 videos for Athena. So if you want to click on it, it will show you the, for example, the workflow when you admit a patient. You need to go over their lab, for example, imaging. So this will be important for extracted and put into a note automatically. Then you can use different tools in the EMR itself, so that let's say you use phrase all the time, so you can set that phrase instead of typing or saving the same phrase every time. You will just put it, and then which one works. You can import that phrase. It's called dot phrase. There are other tools, so you need to work on your note, for example, the history on the first encounter or the follow-up note. So you will need to assess the patient, examine the patient, look at the lab imaging, and so forth. All this will be easily incorporated in your notes, so you will just type or dictate your history, what's the finding, your exam was the finding, and the rest will be put out, and then your plan and your medication, if you want to add new medication or you have to continue for medication, so forth. So this is just for you to review. Same with Epic, we collected some videos as far as for example, here, if you want to do a procedure in the ICU arterial line, so most of the time the steps will be the same. So you want to prepare the patient, prepare the site. So all this will be repeated phrases. So you can have your note in a template, and the changes will be what side, right side, left side, and then what did we use as far as indication of post. So it will be a 2 minute for you to do that as far as the presentation. The same with Cerner, for example, it will have some little long video, it's a 25 minute video. So for some patient learners might be useful to go to other residencies where you use Cerner. So if you review all these videos, I think you will have a good idea about what to expect when you are doing your documentation and communication with other medical staff. For example, if you want to transfer the patient, we just talked about transitional care from the ICU. So you want to put your map about what happens during the ICU stay, and then transfer the patient close to the other doctors who have an idea. And same if you want to discharge the patient from the hospital to home, then you will have your discharge summary so that it can go to the primary doctor. If you transfer the patient from the hospital to the rehab, then it will come as well, the discharge summary. Thank you. I'm going to share the link for that in the chat. Any experience as far as any one of you worked with different or similar EMR? What's your input? I know if you get, let's say, when you get accepted to the program, they will have a 2-week period where they will do paperwork and orientation. Part of it will be training for the EMR that are used in that setting or that. About other places, not in the US, I know some of the practicing like practice in, let's say, Saudi Arabia or the Gulf area or the UK. Anyone wants to share their experience?
Hello, Dr. Nader. Do you hear me?
Yes.
Yeah, I got a chance to work with Cerner. I don't know if you're familiar with it, but it has a lot of similarities to Epic. It's less complicated because I got also to compare it to Epic. Epic is way broader than Cerner. Cerner is a little bit simple to use. That was my experience.
Thank you for sharing. Did you have any training before you start, or you just jump and start there?
It was an externship, inpatient and outpatient. I didn't get any training. Just one of the other students, they helped me understanding it in like 30 minutes, and then with time I got used to it. So no training, but with time I got used to it very fast.
Thanks for sharing. Yeah, go ahead.
Yeah, here in Gulf countries, in Qatar specifically, in residency emergency department, also we use Cerner. And as like being part of the training program approved from ACFMG, we had a training for Cerner here. Like the main thing also Cerner, but they will like do whole 1 day workshop to train you about Cerner. I mean, I can tell like it's quite simple. Like there is no much complicated stuff in it, but from someone he came from developing countries, and we barely use computer in any, and switching to electronic notes and all of that, it was like a huge step for overseas resident, such my case. But like I believe 1 day was like 1 day workshop whole day, then after that asking the other members, fellows, asking the other resident, anyone like had experience or had exposure, and I believe like 2-3 days and you will be familiar with it. Also you have a chance to work with EMR system basically in United States. I feel like a little bit it's more complicated. There's like extra addition in EMR we don't have it. For instance, doing referral or send notification to primary health care when you see patient if you are subspecialty, and like there is some details. I still like we still lack it. Like there is lack in Cerner compared with EMR and those like arrangement and how communicate like all doctors together. You can like note this doctor, like send notification to this doctor, send to the pharmacy, this and that. So yeah, I believe like the difference is little bit, but EMR, at least my opinion, it's more fancy compared with Cerner. Cerner is basic, simple thing to use. Yeah, that's my experience.
Thank you so much, Dr. Marwa, for sharing. Yeah, so the features that are shared for basics that are shared between EMR, and there are some unique features or tools between the different EMR. So each company, they want to put stuff in a different place, for example. I'm going to share with you just some of the screen here. For example, this is a document of documentation of let's say patient name, date of birth, sex, and so forth will be up there. And then on the left side, you will have your divisions or part or sections where you can add orders, you can add more documentation like is it a progress note, is it a discharge summary, and then some of the video of the results. For example, if you want to look at the lab results, you can review them here, or imaging reports, ins and outs, and so forth. Also, they have outside records. So if they scan, let's say, office visit note, you can find it there. The allergies, clinical media, for example, if they have an X-ray image, it can be here, or echo video can be here, and so forth. So these are the basic sections or parts where you can review or you can add and modify. In EPIC, the setting might be similar as far as the basic section, but they can be rearranged or can be different places, and the details might be different, like in the setting here. So there are different features as far as communication also with other EMR or getting the summary. So there's some pieces going over the structure and so forth. But again, it will take a few hours if you to learn how you document. So most of the training programs will set up 13 hours before you start the residency to train you. But if you practice in let's say externship or you round with some physician, you will have an idea about most of the basic things, and it can be applied to different EMR. Let's say I'm familiar with EPIC, when I go to use Cerner or other EMR, more or less I have 80% confidence. The 20% will be as far as finding the things. So I want to start a new node. It might not be on the right side, on the left side of the screen. It might be up on the top left somewhere. So I have to click on it. It might be just an icon where plus 5. So you need to figure out where they put things in the sheet or the page so that you can navigate easily. Sometimes you have to hit certain steps, step 1, step 2, step 3, until you get your node. So sometimes it's just you need help to figure out the how to, and if you figure it out, then it will be easier next time. And I'm sure Dr. Gawa will agree with me. If not, let me know, or if you agree, let me know.
Yes, I do.
Dr. Osama, go ahead.
Hello, everyone. Thank you, Dr. Nadir. I just want to share my experience with when I was working with Virginia Department of Health. We were using 2 different systems, which may be a little bit different than EPIC and Cerner. And the only difference may be there is no option. Of course, it's public health. There is no way, of course, of transition of care or anything in the system. So we used to use VEDS, which is Virginia, stands for Virginia Electronic Surveillance, Disease Surveillance. And another, this is only for patient data and health, the health data related to the patients of infectious disease in particular. The other system is Sarah Aller system, which includes only the clinical scenario and the clinical symptom of the patient, and beside the other demographic and personal data. The good thing about the Sarah Aller system is you will be able to follow up with your patient throughout the isolation period, whatever the infectious disease is. So every day, the system spontaneously send a message, text to the patient in his preferred language, notably English and Spanish. So the patient will respond back by stating the symptom that he's having at this moment. There is a list of symptoms: fever, chest pain, and whatever. And we used this extensively during the pandemic, and it was so effective. And we were able to remotely follow up with the patients throughout the isolation period. Yeah.
Thank you so much, for sharing. Yeah. So you can use different, and it depends on where you are, different systems. But as I mentioned, some of them, maybe 70% will have same features, but there are others will be different features. But some of them, like what you mentioned, communication with the patient, calling with the patient, using remote healthcare or tele, that might be also an option. Most of the EMR nowadays, they have a portal where the patient may have access to their results, like lab results, X-ray, and so forth. And they can also communicate via texting with the provider. They can get some notifications. So they can use email, but most of these emails will have HIPAA protection, or they can contact you using the text your phone so that you can communicate. But again, privacy is the main issue. I'm going to share with you my experience when I was a resident. We used basic EMR, at that time. Epic was just starting. I think it wasn't required by the US government to use EMR, but at the hospital they started. So we used to have dictation. So I see the patient, I dictate my note, someone will transcribe my note into the system. After graduation, we went to practice, and so what I did, I start using this practice fusion on my own. At the time, it was free, and then later it was some cost. I think it's 150 or under 200 a month per provider. But this is not an advertisement. This is just to let you know that they have free trial that you can use for a free period of 1 or 2 weeks or 1 month. And then if you want to, you can test this at that. But what I did at the time, I used the free version. It was basic, the same. It has most of the basic features as far as getting the demographic in place and getting your notes in place, communication as far as sending, let's say, the script or prescription to the pharmacy using the AMR itself, prescription. That was easy for me. Sending my notes to the family doctor, if I had the fax number from the email, that was easy for me. And what I did, I just finish my notes and print them for the nursing home that I go to. So they have my own notes in paper format at that time. Now they have their point and click care system. So the problem nowadays is how these EMR are supposed to talk to each other. I used to go to Spell Hospital, they have Epic. We have patients from another hospital, they have Cerner, and we teach, or we have our own clinic at MSU. We used to have, let's say, a different EMR, but now they came into Athena. So I used to learn 3 EMR besides this one of my own, and it's a mess when you have to communicate between the EMRs. The easiest way is to put your note, print it, send it to the facility, they scan it, upload it to the EMR. Same if we have a patient from the hospital, they put the notes in the EMR, they print it, we get it in the nursing home, they scan it, they put it in our EMR. It's supposed to be a smooth communication between the 2 EMR for transition of care. But because these are different companies and people who are designing this application or this program, they don't put it a priority that when transferring patients from one place to another, they need to talk the EMR to the EMR in the same language, or documents are supposed to transfer easy so that we can get all the information instead of for me to enter all the data that was already entered in the previous EMR to the new EMR. So it's kind of double the work. And it's just difficult from standpoint of view as far as the process and the review. So it's easier for me using the EMR to review all the let's say lab. If I have a patient with hemoglobin 8, I want to look what's the baseline for that patient. So I can look at, if I have access to the EMR at the hospital, I can look at the hemoglobin on admission, hemoglobin on the clinic last year, something like that. So I can have an idea about do I need to send the patient for transfusion or not if the patient is dropping, especially after surgery, for example, and so forth. So it helps if the AMR are communicating, or if you have access to labs and imaging and so forth. Otherwise, you depend on what the other team tells you. Like if they give a good summary, discharge summary of what happened at the hospital, will be at ease as far as getting all the information, because some of the patients, older patients in particular, might not remember or might not collect all the information that were shared with them at the hospital. If they were seen by specialists, if they have a plan, if the patient comes with polycatheter with the plan, we need to send them to urology, we need to try to take it out and see how they do. So if all this were discussed at the hospital, we need it to be written in the discharge summary so that we can continue the same plan instead of us to struggle of we need to try ourselves here, we need to set up the urology appointment, which urology they saw at the hospital and so forth. So going back to practice fusion, you can try this and you can spend some time, see what the big features. You can use just made up patient's name and so forth, play around, see, so that you can get customers used to the AMR. By the time you are using the interviews, you can have an idea about Turner, ethics, and Athena, for example, and practice fusion. And you can talk about your experience. I can mention that I have an idea about the basics of this. I practice on this, even I don't have actual patients, but this is what the features that I know, and I'm willing to get trained in your team or something like that. So you have familiarity when you discuss that in the interview. Hopefully this will help. Any other comments? Go ahead, Dr. Hind.
Yes, Dr. Nader. So I have a question. So if there's like a patient was transferred from like another hospital to our hospital to continue care, and they're using a different EMR system, so how can I get like the information, like other than the discharge summary? If there's anything that I need to take a look at, will I be able to access that EMR? Like for the other hospital, or how can I like, collect these information that I needed?
So again, HIPAA and security is more of the important part for the developers in this hospital system. So for you to access any AMR, you need to have a privilege to that hospital. So if you are in, let's say, in residency training, they will get you access or give you access to the EMR. So to that hospital, if you are working on different hospitals, then you will have access to both different hospitals EMR. If you don't work in that hospital, then again you will be limited to your own EMR where you practice. In my situation, for example, I work in nursing homes. I have access to point-click care. I don't have access anymore to the hospital, for example. So if I need something, I have to talk to our team so that they can talk to the other team at the hospital to give us whatever we need. So I want to access the urology note or the consultation from neurology or psychiatry at the hospital. I didn't have any on the discharge summary for that. So I have to talk to my staff here. Hey, there is missing some consultation notes. I need a note from urology. I need a note from the neurology or your side. So they will call the hospital. Hospital will make a record for someone. They communicate with case manager or someone who has access they will tell them, hey, I need this. So they will get the information from the hospital to me, either fax it or print it, and then they scan it to the email. Then I will have information in my email. So this is another way of doing it. So it's supposed to be smooth. It's supposed to be easier for one email to access another email, but it's not happening. So you need access or privilege to other places where you need your information. I hope that answers the question. Go ahead.
Yes, it's very informative. Thank you, Dr. Nader.
You're welcome. Thanks. Any other questions or comments? I know some of you might have extended or extensive. You went to the hospital, clinics. What's your experience? Can you share? I just want to give you an opportunity to share your experience. Anyone of you wants to share your exposure, your knowledge about this or personal stories? Not necessarily in the US, could be other places. I know also from other countries where they practice or practicing. If no comments or any suggestion, we can go to next part, which is project updates. Anyone with any ideas about research projects? I know that we have some projects that are going on, abstract and manuscript, and apps are in development phase. So anyone wants to share their project or update us? I'd like to thank our postgraduate team that published the article in TGRF about blue, modified blue, and the TGRF manuscript that was accepted and published. So congratulations. Any other manuscript or any other work of project abstracts, apps? Any new ideas about projects that you need to work on? So we have two conferences coming in the coming 2 weeks. One of them in Canada, one of them in California. So we have one poster which is presented in each of these conferences. So congratulations to the team and good luck with presentation there. I know the dental group are working on an app that's informative or information kind of based about some of the indications that are used or the interaction with the results on dental hygiene and so forth. So we'll be finalizing that and have some suggestions.
Assalamu alaikum, Dr. Nader.
Alaikum salam wa rahmatullah. Go ahead.
Yeah, so for the abstract that we submitted, me and just a couple of my members were working on finishing off the manuscript, inshallah, and then hopefully us submitting it to one of the sites, inshallah. So we should be done that in the next week as well.
Sounds good. What's the title again? Remind me.
It was the effects of anesthesia on postoperative cognitive dysfunction. We also had the opportunity to update. So like we did some more research and we were able to update it with newer researches to add it to the manuscript. And so inshallah, like on the discussion part, we also included that as well. Yani the newest updates from when we submitted it to 2023.
Excellent. Excellent. That's great.
And sorry, to answer your question earlier, I didn't get a chance. My child was crying, but I got an opportunity to work with Epic because I had done a rotation in Michigan, and so it was interesting. You know, at the beginning it was hard, but like just being able to navigate it and seeing all the patients made it easier. I think the struggle that I had is here in Canada, I also had the opportunity to work with different physicians, but the healthcare system is so different. So it was almost like relearning everything, because here it's universal. So you have the health card and like your information is from, you know, the minute you enter Canada until you pass, but all the information is there irregardless of where you go to. Whereas in the States, it was, you know, depending on which system you use and if you're providing that new information to the physician. So I think just navigating everything was a challenge, but alhamdulillah, I was able to keep up with it. But yeah, it was definitely a different experience.
Thank you for sharing. Yeah. Yeah, so here in the US, there is a system where the army or the government has a certain system for veterans to be seen by physician certain centers. So this system also is like Canada system. They have it all over the US. So it's only one system where they keep record of the people in the army or retired. So you will have all the information regardless of where the patient was born or moved from one state to another state. So you will have access. So it's one system placed in all over the United States. So you can have access. But that system is closed as well. So it's only for people in the something like that. So you will have some ideas when you come to the US office, so you get into residence. Thanks for sharing. So Dr. Nod and his team will be presenting in California at the end of the month. Thanks for sharing. So he will be presenting the poster that was printed. We will update that in the website, and he will have some hands out. So people who come to the conference will have hands out, or if they want to scan the poster, you can use the QR to get information, contact information, so forth. we will work also on the other poster, finalize it, and hopefully we can get it ready for the conference in Vancouver, Canada. Any other updates? So there is a question about certificate. So usually what we do is if you join the fellowship here, this program, we want you to at least get involved in one research project. And the idea is to get the training and skills to know how to start, finish a project. So by the time you start your residency or any other work area, you will have the benefit of getting research idea and then start on that idea. You can start a team, you can identify tasks and divide the task between the team members, and then hopefully you will finish that project and hopefully it will be published or presented in a conference or paper journal. So we don't expect you to get the whole thing successfully finished and presented or published, but at least we need you to go through the experience itself. So if you finish at least one project by the time you are finishing this fellowship, we'll send you a certificate. And hopefully this will help you also when you apply to the residency programs during the interviews, and hopefully you will have good knowledge of research in general, engineering in particular, and then you can apply the same concept if you are going to different specialties like from the same concept in neurology, spine, and present, and so forth. I know when you go into internal medicine or internal medicine, for example, you will go after that. Some of you might want to first of all go to subspecialty calculus, for example. So to be competitive, you need some research experience, some publications, and so forth. So this is hopefully this fellowship will prepare you, and equip you with some tools, some skills that you can use in the future if you need to. We are working also with some of the teams here to develop some apps, and we are successful in publishing some of these applications, mobile apps, and the store, like the Google Store. So if you have an idea, or if you want to develop an app also, we are here to help. So it's a learning process. When you learn it, it's useful for you and your target users, for example, for educational purpose, for medical students, for residents, and so forth, or for your patients. So hopefully it will help some people out there. Thank you. Any other questions, any other comments, any other ideas of suggestions? So Dr. Abdullah was accepted recently, so he was asking about the fellowship. So again, we divide this group into teams, and you will be assigned to a team. Each team will have a team leader for a period, and that can be changed between the members of that team. So the idea is to have each team participate in these meetings and work together to achieve some of the learning objective of the fellowship. So you, along with your team members, will work together either to educate us about the topics that we share, or if you want to get new ideas, we can discuss. If you want to learn more about fellowship dynamics and the details, some of the senior members will guide you through. So some of the leaders will answer your questions. And hopefully we are here to help you as much as we want you to help us. And every one of us can contribute somehow, even small pieces will help each other. Any other questions, comments, suggestions, ideas? If not, then I want to share with you that again, AGS, the American Geographic Society, is accepting abstracts for posters, poster presentation. So if you are working on some of the abstract, or if you have idea, you want to work on some of the research ideas, let us know so that we can work to submit. Again, the other group is and the group, which is the American Geographic or Medical Director Association. They also accept are accepting abstract for poster presentation. So if you are working on this area, you can work and hopefully we can submit some abstract. The ANDA, they have one, or they have some spots for some of the fellows or residents or medical students to attend their meeting. That meeting will be in March, April, somewhere next year. So if you want, if you are in the US, try to approach the ANDA website and the chapter in your state and ask about the future program. So the future program is basically you write as the like a personal statement of what's your objective, what's your goals in the future. If you are interested in helping other adults, how can a training and your future will be like, and how can you participate with ANDA so that you can get some of the skills to apply these skills or experience to help all the others in the future. So they can pay for you to attend the meeting. They can sponsor you your hotel and your stay, maybe transport and travel expenses. But you need to write like one page or so as a personal statement, something like that. And you need to have someone to support you in your goals in that. So if you are in a state in the US, try to reach out to them, see what the requirements and how can you apply for this fellowship, or not fellowship, but it's future program. It's very useful. I did it when I was in my fellowship, so I applied here in Michigan, and they paid for me to attend the meeting and all covered hotel and transportation. And it was useful because I met other fellows on future programs, fellows from different states, and we discussed and we're helping each other. So it's just, you can make some connections in that regard if you are interested in geriatric in general and providing good care to all others. All right. Any other comments? Any other suggestions before this meeting? So if not, then we will see you next meeting. Thank you so much all for attending today. Thank you for sharing and those who shared their experiences and comments. I wish you all the best and good luck with your application process and interviews. We hope to hear good news in the near future, and I wish you all the best with your projects as well. Let me know if I can be able to help. Thank you. Have a wonderful day. Night. See you next week. Assalamu alaikum.
Alaikum salam. Thank you, Dr. Nader. Jazakallah khair.
Thank you, Dr. Nader.
Thank you so much, Dr. Nader. Thank you.
You're welcome. Thank you.
Jazakallah khair.
Thank you, Dr. Nader.
Thank you. Have a good day.
Thank you, Dr. Nader.
You're welcome.
Good
Thank you.
evening,
Have a
sir.
wonderful day.
Bye.
Bye. Thank you.
Assalamu alaikum, Dr. Nader.
Alaikum salam wa rahmatullah. Go ahead.
I just wanted to ask you, so I know that many of the teams, they did the apps for like children and screening and stuff, but I was like just keeping in mind, like I wanted to kind of, well, this is just like, I'm just throwing it in the air there, but I wanted to do almost like a screening app or a screening guideline, but for adults. So like, for example, women like pap smear, mammograms, like prostates, like my thoughts are still like everywhere, but I was, that's kind of the idea. I just wanted to get your thoughts about that and if it's something you think that's doable.
I think it's a great idea. I think it's going to be useful. So you want to develop the app for the patients, is that correct?
Yeah, but I think I want to focus it on like adults, like I think 50 plus.
Mm-hmm.
I think, I guess, like depending on the screening,
mm-hmm.
That will affect the age group, but that's what I'm thinking right now. I'm going to do more research, of course, on it, but I kind of just wanted to get your initial thought.
I think it's a good idea. To agree. And
okay.
We can go ahead and research it and see. And
okay.
Yeah.
Okay, I'll probably get more information and probably reach out to Dr. Ahmed and see if she's available to help me with that then, inshallah. I'll keep you posted and let you know how it goes.
Yeah, so thank you.
Okay, Jazakallah khair, Dr. Nader.
Dr. Ahmed, go ahead.
Hello, Dr. Nader. First of all, thank you so much for sharing your knowledge. It was very insightful to me. So regarding Dr. Rayan's question, we are working on this application, but on cancer only. So Dr. Rayan, if you are interested, we can add you to our team. But I don't know if you mean like screening for other conditions or only cancer, because we are only working on cancer screening.
I'd be more than interested to join your group. Thank you so much.
You're welcome.
Oh, I appreciate that. Yeah, I was like, again, it was just an initial thought, like just kind of doing a screening guideline for adults. But I think focusing it on cancer, yeah, it's more direct and, like I said, focused. So thank you so much, Dr. Ahmed. I appreciate that. And I'm really looking forward to working with you.
You're welcome. We're happy to have you. Thank you so much.
Go ahead, Dr.
I just have a quick question to Dr. Ryan. Is the plan to focus on one disease screening or screening for different diseases? I'm also interested in that. Is it like a directive of screening of different diseases or one disease pattern?
So we are including all cancer screenings that are available according to the US Preventive Service Task Force. This is our reference. And the app is mainly directed to patients. So we are trying to make it in a simple way. And it's mainly like information based, but we are also like thinking about adding other pages, like a page where users can add their history. If they screen for colon cancer, for example, they can add this to their history so they don't forget about it.
Okay, I got it. So it's just a preformed paragraph or preformed guideline of cancer, and then within that guideline, you can kind of include all different cancers. It's not specifically for one disease, right?
I couldn't understand your point, sorry.
Oh, yeah. My question is, Dr. Ryan was raising a question about preparing an abstract or an app which focuses on screening of, let's say, adults above 50 or 55 or a specific disease pattern. My question now is just, are you guys trying to build a directive like information app on all types of cancer or a specific type of cancer?
I think
No, it's
oh, sorry, go ahead, Dr. Amal.
yeah, so it's all types of cancer, not a specific one.
Okay. Okay, thank you. Go ahead, Ryan.
You're welcome.
And you can extend that, or you can develop something similar to all the adults, not necessarily only the screening for cancer, but let's say screening for risk of fracture or osteoporosis and so forth. So in addition, or it can be a separate one for users. So if they want to do mammogram, for example, if they want to do DEXA scan, for example. So when do they do it, and if they have some results, and to get these results in the app, something like that. So I appreciate your sharing, but also think about what else can be done out of the box.
Yes, sure. That would be a great idea. So also I was thinking about making an application that targets depression in elderly. So it would be like informative, and at the same time, I'm not sure if this is doable or not, but including like a risk score or something like that. Like a score can calculate the risk based on a questionnaire. So I think it's doable, but let's see in the future.
I think that's I think it's a really good idea. I think you can even maybe like do it for like the nursing home staff, like the nurses and the caretakers, where they can easily just go through the questionnaire on the app and then do the assessment, and then like hopefully it could like generate some sort of like information, and then I guess that can almost be like a basis for how the staff can approach the care.
Yeah, that's great. We never targeted like a healthcare provider before, so this is going to be interesting.
Yeah, really interesting. It's
Yes.
Thank you so much, Dr. Nader, for giving us this platform to be able to like discuss and like come up with such great ideas, you know.
Sure. Thank you for your participation and contributing to the fellowship. So thank you all.
Thank you for the opportunities. Thank you so much.
You're welcome.
Alaikum assalam. Have a great weekend.
Assalamu alaikum. Thank you.